Hi, this is video 4, which is about other psychiatric diagnoses in agitated patients, and we'll look at mood disorders and substance use disorders in this chapter. So let's start with mood disorders such as bipolar disorder, especially acute mania. In this day and age, the diagnostic manual says there's bipolar 1 and bipolar 2. More commonly, it's the bipolar 1 mania that you need to be concerned about when it's encountered in the emergency setting. When we're thinking of acute mania, that's going to be people who could have any of the following kind of things: euphoria, irritability, fluctuating anger, even up to rage and hostility, delusions, especially paranoid delusions, hypersexuality, or also hyperreligiosity, especially believing one to have special religious powers or connections. Somebody's hyperactive, they can't sit still, they're just moving all around. They've got rapid speech, very talkative. They can also be very impulsive, and racing thoughts are something we see quite a lot. And if you hear from people, it's like, oh, our family member here has not slept in the last 3 days, that should be a real trigger that this could be mania. Realize that there's lots of great data out there that show that patients with acute mania are really at a heightened risk for suicide, especially when we have what we call a mixed mania state, where there might be symptoms of mania, but also some dysphoria, some depressive symptoms, feelings of being distraught or that their life is not going the way they want to. And they have enough energy to really go ahead and do some dangerous things to put themselves at risk. So it's really important to take a good look at patients with mania and rule out that they're not also acutely dangerous to themselves. And also realize that people are dangerous to themselves and with heightened energy can also be danger to others, because sometimes maybe the idea comes in your mind, well, I'm going to kill myself anyway. I might as well take out a few people with me kind of thinking. They can really have poor impulse control. I've seen, unfortunately, very, very risky behavior. I have seen in my clinical career so many cases of people who were brought in after doing something that the average person wouldn't do, like get in a car and drive 800 miles in one direction in the middle of the night for no reason, with no destination, and just seeing how fast they could go the whole way. Going out and going into dangerous neighborhoods and shouting inappropriate things or acting in an unusual way, putting themselves really in danger. And there's a kind of a grandiosity that you see where people will feel like they are superhuman and they're impervious to harm. And so why not walk into this dangerous neighborhood and start shouting insults at everybody you pass, because nobody can hurt us? Part of that grandiosity really puts people in danger, and we need to recognize that when we're doing a risk assessment. At that same time, recognize that of the serious mental illnesses, bipolar 1 disorder often has people who are very high functioning when they're not cycling into mania or serious depression. And in fact, we know that there's celebrities and big corporate CEOs who have bipolar disorder, and when they're not in one of their high cycle stages and they're really at baseline and doing it really well, they can be super high functioning. What we found, when you talk to people when they're in mania, they often really remember it, and they still have that level of intelligence that they have when they're not acute. And they often really remember things when they're in remission. So it's important to work with them with that in mind and recognize that don't say anything goofy or something that you think, oh, they won't remember it because look at their condition now. They're probably going to remember it. And they'll remember it was you that said it. So treat them just the way you would want to be treated yourself. Do the golden rule, basically. We move on to comorbid substance abuse in psychiatric conditions. Sometimes it can be really hard to tell the difference between psychiatric type symptoms, whether they're caused by an endogenous condition such as schizophrenia or bipolar disorder, or that these have been induced by using, let's say, a stimulant like methamphetamine or cocaine or other medications. When somebody is having what appear to be symptoms that might be caused by a substance abuse, especially high energy, hypersexuality, behaving in such a way where it seems like they're not thinking clearly, or if they're agitated, angry, lashing out, combative. If you think that it may be substance-induced, especially stimulant-induced, such as by methamphetamine, it can often be really helpful to not try to just say, okay, this is what this is, let's treat it right away. This person has schizophrenia and methamphetamine. you may want to give them some time to detoxify in front of you and then make a reevaluation before coming to a final diagnosis. Unless you know something about the patient, I mean, if you've got a positive drug screen for one of the stimulants, which tend not to be remaining in the bloodstream all that long, so it's probably pretty acute, you can go ahead with treating with the substance abuse condition in mind. Also remember, a lot of our folks that we see in the emergency department may have an underlying schizophrenia or bipolar disorder that's being exacerbated by substance abuse. And to see what there really is going on, sometimes giving a chance for them to come down a bit, sometimes treating a little bit with some medications that will help improve their condition as they're detoxifying, will really help us with our overall treatment plan and our decisions on disposition. We should really avoid prejudging what's going on with somebody unless we really have a good idea. We've got either lab data or a good history or a good person who's accompanied to give us collateral history to help us know what's going on and confirm what the condition is. So overall, our key points are to recognize first that there's many other behavioral health conditions that can lead to agitation besides just schizophrenia, definitely acute mania, and certainly a very high percentage of agitation in emergency settings is going to be due to substance intoxication, sometimes substance withdrawal. Recognize that acutely manic patients often have really poor impulse control, and they can unpredictably become a danger to self or others at the drop of a hat without their thinking that that's a problem. Because of their high energy, because of their racing thoughts, they can suddenly become dangerous to themselves or others. So always keep that in the back of your mind. Make sure that when you're working with somebody like this, that you're considering that even though they know not seeming to be agitated, aggressive, or violent at this point, it could happen at any moment, and make sure the staff and everybody else who are around are aware of that. And finally, it can be difficult to tease out symptoms of psychiatric illness when a person is acutely having substance intoxication or in a withdrawal state. So if it's possible to give them a little bit of time to see if there's some detoxification, if that improves their condition, that can be useful and that can help avoid a lot of problems.